Postoperative hyperalgesia and tolerance due to neuroadaptation. The use of opioids in the perioperative field, they have their drawbacks. When you use opioids as a mainstay of analgesia intraoperatively and postoperatively, the drawbacks are they are non-potential respiratory depressants, and they also affect the gastrointestinal function. They are notorious post-op nausea vomiting drugs. They cause pruritus, they cause urinary retention, and some patients get addicted to that. In major surgeries, patients who stay in the hospital for longer periods, by every day if you start giving them morphine or pethidine, there is a chance that they can become addicts, and even after they get a good relief, just to enjoy the euphoria that is produced by these drugs, they will say they have pain and they will start asking for that, and somehow become an addict and to use it even after discharge. So these are all the unwanted effects of the usage of opioids, which triggered the concept to choose opioid-free or opioid-sparing anesthesia. And especially in patients with obesity, sleep apnea, or other respiratory disorders, this respiratory depression is a very important deterrent for use of opioid, especially if you do upper abdominal surgery, which will squint the diaphragm and aggravate the respiratory function. In addition to that, usage of opioid will further depress, and that is another reason why opioid-free anesthesia was thought of. Similarly, impaired gastrointestinal function leading to postoperative ileus or leading to anastomotic leak, all this bowel surgery is another reason for thinking about OSA. And opioid-induced bowel distension may push the diaphragm flat and cause atelectatic lung base, which will also aggravate the respiratory problem. And once the basal atelectasis happens, patients go for increased work of breathing, leading to respiratory failure, needing re-intubation and support of the ventilation. And abdominal distension can lead to surgical wound dehiscence. And opioid-induced gastroparesis leads to the chance of aspiration during anesthetic induction or in the postoperative phase when their consciousness is slightly offended. And patients in critical unit, they are not able to absorb the nasogastric feeds and may drift into malnutrition. And opioid-induced postoperative nausea vomiting, especially following eye surgery, upper gastrointestinal surgery, head and neck surgery, neurosurgery, all these things can either precipitate a bleeding or a CSF problem, like a ICP raise or a fluid leak. All these things can happen. And they also cause cell-mediated immunity, which depress the cell immunity, which can result in recurrence of cancerous tumors. And urinary retention may sometimes require urinary tract catheterization, and which may produce a secondary urinary tract infection. And as we saw in the earlier slide, ERAS protocol to make the patient ambulant and discharge early, use of opioid will be a hindrance to that. So these are all the reasons why people have started using. Of course, post-op hyperalgesia and tolerance is another one. And to avoid all the above unwanted side effects, opioid-free anesthesia was recommended. And that consisted of two things. One is multimodal approach, using two things, that is non-opioid analgesics plus regional anesthetic techniques. So when you combine both these things, you can achieve a state of opioid-free anesthesia. So what are all the non-opioid analgesics that are used as adjuvants here? Lignocaine, alpha-2 agonist, beta blockers also. I think, did you mention about esmolol?
No,
Vidya?
sir. No, sir.
Okay. So beta blockers, ketamine, dexamethasone, gabapentin, NSAIDs, paracetamol. So taking one by one, the most preferred drug nowadays is the alpha-2 agonist. which has become made a big revolution after it has been introduced. And this is the ideal drug that is chosen for OFA regime because of the multi effects that they have: sedation, hypnosis, anxiolysis, glucolysis, and analgesia. And dexmedetomidine is the most sought after drug in this. It preserves the airway patency and also produces a normal sleep pattern. And it has some bronchodilator property. And common side effects are it lacks the common side effects of opioid like respiratory depression or urinary retention, pruritus ileus, etc. And it offers better heart rate control perioperatively and can cause transient rise in blood pressure. More than the hypotension, it can cause like hypertension. It is a biphasic response. Initially, it will cause a hypotension, then it will cause a hypertension when you use this drug continuously. And the second drug, lignocaine, has an analgesic, anti-inflammatory, and opioid-sparing effect. Downregulation of neutrophil degranulation is thought to be the primary mechanism behind the anti-nociceptive effect of lignocaine. So the neutrophil degranulation produces not just the normal sodium channel blocking from the cytosolic sides of the neurons. It is the other mechanism which is responsible for the analgesic property. And intravenous lignocaine infusion decrease the anesthetic and opioid requirement, reduce the incidence of nausea and vomiting, faster return of bowel function, and improved quality of recovery. And ketamine is an NMDA antagonist, all of you know. And, it reduces opioid requirements, especially in patients who are opioid addicts. This is the drug of choice for treating their pain in the postoperative period. And the combination of ketamine and magnesium has a balancing effect. Ketamine produces tachycardia and hypertension. Magnesium causes bradycardia and hypotension. So when you combine both, the opposite effects get neutralized and you get a more stable hemodynamic status in the patient. And the magnesium also acts on the NMDA receptors and also has an effect on preventing the calcium influx. And it is used as a preoperative analgesic in doses of 3 to 50 milligram intravenous bolus or 10 to 15 milligram as an infusion. And all of you are aware of this drug because it is a common drug used in preeclampsia to prevent seizures. So all of you know the details about that. And the beta blockers, it is esmolol is used to use the intraoperative and postoperative requirement. And the other drugs that are used are gabapentin, pregabalin, which are calcium channel, indirect calcium channel blockers, and also mostly for neuropathic pain. And they cause more sedation. That is a disadvantage which she mentioned. Dexamethasone also has got a analgesic property in doses of 10 milligram per kg, in addition to the benefit of antiemetic and anti-inflammatory effects. Paracetamol, all of you know, are routinely being used, and that is considered as one of the mainstay in the usage of opioid-free analgesia. But too much of paracetamol, that is not more than 3 grams per day, should be used when you use intravenous paracetamol because of hepatotoxicity. And regional analgesic techniques, including peripheral nerve blocks, facial plane blocks, are all used. And facial plane blocks such as serratus anterior, erector spinae, quadratus lumborum are also becoming very common modes of using opioid-free anesthesia. And simple wound infiltration, the local anesthetic, is also very highly effective. And the use of tumescent local anesthetic, which I have found extensively used in microsurgical procedures for harvesting the graft or flap, used to give analgesia for up to 18 hours. So it's a nice way of producing good post-operative analgesia also. And OFA, which avoids intraoperative opioids by any route, has specific advantages because it clears all the unwanted side effects. And disadvantages, as she rightly said, alpha 2 agonists have to be used in caution, especially in patients with cardiovascular disease, where they have an AV block, or elderly patients on beta blocker. Use of alpha 2 agonist should not be taken in a casual manner. And relative contraindications are patients with coronary stenosis or acute coronary syndrome, uncorrected hypovolemic shock or autonomic dysfunction. Our potential for awareness is always there if there is inadequate hypnotic component. Midazolam has to be part of that to produce hypnosis and sedation. And there is definitely a learning curve to use this to practice OFA, and so that you can keep the patient comfortable. So these are the points to be included in that. So probably you have left out something, you can include those points in that. Okay.
Yes, sir.